Hi, everybody. Thank you so much for joining us this morning. My name is Justin. I'm a clinical researcher for Cure CMD. I'll be moderating the session today along with Gustavo. Hi, Gustavo.
Hello. Hi, everyone.
We're very honored to have a couple panelists joining us today, and they will be discussing LMNA care, touching upon key areas of proactive surveillance and care, taking some of your questions, and then also relating it back to our plenary session this morning on clinical trial readiness. So we'll get to introducing our panelists in a second, but first I must read to you our disclaimer statement. So let me go ahead and share my screen. So the information and opinions shared by our panelists will be generalized statements and are not intended to be interpreted as a medical consultation or substitution for medical care. Please consult your local healthcare providers regarding any specific health-related concerns. This session is being recorded and will be shared on our public YouTube channel after the conference portal closes on August 31st. So with that said, why don't we take a moment to introduce our panelists. Panelists, can you please state your name, your institution, as well as the discipline?
Sure, I'll start. I'm Dr. Felice Heller. I'm a pediatric cardiologist. I'm located in Hartford, Connecticut at the Connecticut Children's Medical Center. And I have an interest in clinical care for cardiac involvement for muscular dystrophies, particularly LMNA.
Reagan.
Sure. I'm Dr. Reagan Foley. I'm a pediatric neurologist and neuromuscular specialist. I work at the National Institutes of Health and National Institutes of Hope, we say as well, and focus on congenital onset muscle diseases.
And I'm Karsten Barnum, and I'm a pediatric neurologist, neurogeneticist at the NIH, working with Dr. Foley there on early onset muscle diseases of many kinds, including LMNA.
Wonderful. So why don't we jump right into some of these questions that the audience members have asked us. The first one is, was asked, are there any off-label or over-the-counter medications or supplements we as the LMNA community should be taking?
Reagan, you want to take a step at that?
Sure, exactly. So there's nothing that we would say would be specific to LMNA-related CMD would we recommend be taken. There's nothing that we have data that would say would be helpful in terms of what we call nutraceuticals, a vitamin or a supplement. The question always remains, I think probably discuss this a little bit more, is the question of whether or not a trial of steroids, corticosteroids, should be considered at some point in time, and for how long to try before we see if there's a change. But in terms of like anything nutritional or supplemental, we don't have data that there is something that should be trialed. Again, many of these supplements are safe. We just don't know if they would make a difference per se.
Yeah, and steroids obviously are not an over-the-counter medication, so maybe we get to that later in the discussion. Vitamin D, of course, and bone health are absolutely essential, and that needs to be monitored with your care team to make sure vitamin D is optimally substituted, because bone health is not specific to LMNA, but it's always a concern in congenital muscle disease, and it's something we can really optimize. Dr. Heller, any other recommendations?
No, I think that point about bone health is very vital and often gets overlooked. So that's an important thing to remind your providers about.
And one last kind of plug for that as well is that we talked about yesterday during the COVID-19 talk that it's not only so essential for bone health, but also it helps support the immune system. So for children, we often say 600 to 1,000 units a day, but your local provider may actually have recommended a higher dose if your serum vitamin D level was a bit low. And so making sure you recheck it if it has been low, that it is now adequate, and then staying on a regimen to maintain an adequate vitamin D level.
Thank you, Dr. Foley, Dr. Baumann, and Dr. Heller.
And is there a minimum age where they have to start with vitamin D?
That's a great question. Yeah, I don't know.
Not
Dr.
really. I mean, vitamin D is important for the entire span of life, from infancy to adulthood.
Exactly. So I had pulled some of this data when I was looking at the COVID-19 data, and typically when you're an infant, it should be enough in the formula, but it's never too early to start. And I think for infants, I think they say about 400 IUs a day if it is found to be low. So it can be started at a young age.
It's an, I don't know whether there's a question about nutrition somewhere in the chat coming up, but that's an issue that in our LMNA community is requires really the help and expertise of a nutritionist as well. The reason for that is, as you probably all know, that the fat distribution can be different in children with LMNA in that there often is very little subcutaneous fat, and the children may look undernourished, but part of that is also the disease phenotype, the disease expression. And so it is important to really calculate and caloric needs and the fullness of a healthy nutrition. In addition to just looking at the weight curve, it's important to kind of calculate really the need and caloric expenses in a child with LMNA.
So another question we have here by Doan Ann Hunty, I hope I got that name right. Our son has experienced a few hypoglycemic episodes since 2019. Is this common in LMNA?
Maybe I can start on that. So it is something that we now really are aware of in different subtypes of congenital muscle disease. And so we've just published a little case series on that in LMNA, in LAMA2 related dystrophy. But it is really related not so much to the specific disease subtype, although may play some role as well, but there is a tendency early on in life to hypoglycemia in a number of congenital muscle disease patients. The reason for that is that the liver isn't really yet fully mature to provide the buffer and storage that you need to keep your blood sugar up at normal levels over an extended period of time. And so while the liver is growing and maturing, the body often uses muscle as a source to make a glucose, blood sugar, out of amino acids. So it will use some of the amino acid storage in muscle to really keep blood sugars at a level. And because muscle is the primary problem in congenital muscle disease, that may not be adequate for extended periods of fasting or extended or particular periods of need, such as intercurrent infections. And hence there appears to be a higher risk of hypoglycemia occurring because of that. And a number of our children have undergone extensive medical and metabolic testing to see is there any other reason for hypoglycemia, and invariably none is found. It's really that that storage problem that needs to be overcome. And so at the first signs of hypoglycemia, meaning decreased awareness, sleepiness, really nutritional supplementation is all that's needed to keep the blood sugar high. Extended periods of fasting should be avoided. Frequent feeds are necessary in that.
And this also has come into play if there's a surgery plan, like a gastrostomy tube placement or ICD placement, the anesthesia team should be aware that the intravenous fluid should have enough glucose to account for the potential of hypoglycemia post-surgically.
Looks like we have another question from our audience, from Jonathan Alvarez. I believe they're trying to say, does there exist a treatment currently on advanced treatments for those with LMNA?
Yeah, actually, there is a two-part question, because he started asking for top 3 priorities for research and treatments for the LCMD for the next 2 years.
Maybe that was touched upon yesterday in the research section for LMNA as well. So there are this question doesn't fit neatly into one of the sessions. So there is I think from a molecular point of view, the really top need is to find, like Dr. Giselle Bon was outlining yesterday, to really find a technology that is able to inactivate the mutant LMNA that is causing havoc, at the same time replacing normal LMNA so that it is at high enough level for the skeletal muscle in the heart to be used. The heart is particularly sensitive to low levels of LMNA, so one has to really replenish that there. That I think is basic science research priority number one. I'm not a bench researcher in LMNA, but I think to figure out what the mechanisms are that really cause muscle disease when LMNA is dysfunctional in the nucleus is still somewhat enigmatic, and that really needs to be worked out in greater detail, because there could be molecular interventions that are closer to the clinic than we think, and that's ongoing. And in this session, in terms of care, research priority number one is predictive and proactive cardiac care. I think that is, for me, the overriding concern in LMNA of this early onset variant. Our retrospective natural history has really pointed out that with the early onset, with more severe disease, there is, of course, predictable challenges to motor function, loss of ambulation or not even achieving ambulation, as well as to respiratory function. So the more severe you are from a skeletal muscle point of view, the more severe your respiratory pulmonary involvement is going to be. However, we are very good at predicting that and intervening with that. The big kind of dark part of that predictive natural history is the cardiac. How do we anticipate cardiac incidents? How do we monitor for them? How do we treat them proactively? When do we intervene with what technology? That is, I think, my research priority, number one on the clinical care front, but this is Dr. Heller's territory.
Yeah, I want to add that one of the priorities is to be clinical trial ready for this community, and the retrospective study that was already done and mentioned by Reagan this morning, and to build in a prospective natural history study, and there is an effort going on now with international researchers and clinicians to put this in place, a prospective natural history study for LMNA.
Yes, and the proactive cardiac part needs to have a big role in that. I don't know whether Dr. Heller, I see Beth McNally is in the audience as well, and she can also chime in on this.
Sure, I can. There was a specific question from submitted from one of the families about cardiac care, and maybe I can sort of launch into that at the moment. I put together a couple of slides to talk about cardiac care and the different devices and how to be proactive about this. So is this a good opportunity for me to show my slides?
Absolutely.
All right, I'm going to share my screen. All right, can you see my slide presentation? Good.
Yes, we can.
Great. Okay, so I just wanted to start by saying that when we look at cardiac problems in LMNA muscular dystrophy, they fall into two different categories that are somewhat related, but there are electrical problems, and then there are pump problems, meaning the degree with which the heart squeezes and how strong it is. And both are important and can lead to significant clinical symptoms. So within the electrical realm, there are fast rhythms, slow rhythms, and then the sort of most dreaded complication, which is sudden cardiac death. And in order to understand what these rhythms are, I wanted to show you this. This is a diagram of the heart showing the heart has four chambers. It's a an organ made of muscle, and there are two upper chambers called the right atrium and the left atrium, and then two lower chambers called right and left ventricles, which are, and the walls of the heart are made up of muscle, which can be impacted by the LMNA muscular dystrophy. But the piece that I think is less often appreciated is the electrical system, which is shown in the yellow, these yellow fibers. This is where the electrical impulses are generated, and they start at the top of the right atrium here. This is the right side of the body, even though it's the left side of your screen. This is called the sinus node, and it generates an electrical impulse every time you're supposed to have a heartbeat. And that electrical impulse then travels through these specialized conduction fibers throughout the rest of the heart. And when that electrical signal reaches the muscle, it causes the muscle to contract. So sometimes with LMNA disease, there can be premature beats coming from the upper or the lower chambers because parts of the electrical system become a little bit more irritable and fire early before waiting for the appropriate timing in the normal sequence of events. And sometimes the atrium, the upper chambers, start to fibrillate, which is where they beat in a discoordinated fashion. Instead of all the parts of the heart working together, it just kind of quivers instead of contracts. And the atrial fibrillation starts, it can start in childhood and become progressively more problematic as you get older. Oftentimes we'll see just brief runs of atrial fibrillation for a few seconds at a time, which come and go. But then as the child ages, the atrial fibrillation becomes more persistent or more prolonged. And the longer you spend in atrial fibrillation, the less well your heart works and the more complications you can have. And then a little bit later in life, so that the premature beats happen early in childhood. The atrial fibrillation often starts in childhood through adolescence, and then the ventricular tachycardia. These are dangerous fast rhythms arising from the lower chambers. That tends to be a little bit later onset, often in the teenage years or adult years. And not every LMNA patient experiences all of these, but these are the things that we're always looking for. And then very importantly are slower rhythms. Sometimes the electrical signals, instead of becoming irritable and firing early, they actually the signals don't travel well from the top chamber to the bottom chamber of the heart, and that's called heart block. And there are various degrees, and it tends to be progressive, where there can be milder degrees of heart block early in life, and then it gets more profound, so that when it becomes a complete heart block, the heart rhythm becomes extremely slow and not, so it doesn't pump effectively. And there also is this term called the sinus node dysfunction, which is when the top sort of natural pacemaker function of the heart just becomes sleepy, and it doesn't fire every time it's supposed to. So all of those things, if it's a fast rhythm, that's generally treated with medications. Slower rhythms are often, we need to treat that with a pacemaker. And then the fear of sudden death, which can, when the irregular rhythm becomes completely unstable all of a sudden. And that can happen without warning, and it can happen at any age, although the older you get, the higher the risk. And that can be preventable with the implantation of a ICD, which is implantable cardio defibrillator. And I'll have a few more things to say about that. The importance of early prevention and putting in an ICD before you experience problems can be really helpful, because it often happens without warning. You don't know when the optimal time to place them is, and we'll talk about that. And then lastly, the pump problems. The medical term for that is cardiomyopathy, which just means heart muscle disease. And it physically manifests as a weakened heart muscle. And it can lead to a clinical syndrome that we term heart failure or congestive heart failure, which is just basically saying that the heart pump function is inadequate to supply the needs of the body. And it's a chronic problem, and it happens slowly. This is different than a sudden event, which can cause a cardiac arrest. Heart failure or congestive heart failure is a long process that can often be managed. But heart failure tends to acutely worsen. It may acutely worsen after a period of stress. For example, an illness, an infection, a major surgery, anything that puts stress on the heart can kind of tip it over the edge. So the goals of cardiac care are, we obviously need to look for the rhythm problems, and we need to look for the pump problems, the function problems, and then decide how to appropriately use both medication and the technology, the hardware. And I'll talk about what these devices are: the Link device, which is a monitoring device, and the ICD, which is a treatment device. And then the goal for all of this, of course, is to improve the quality of life and the life expectancy. So I'm going to start with the pump problems because that's a little bit simpler. This is most typically seen in teenage years and beyond if it's going to develop, and it doesn't develop in everyone. The onset, as I mentioned, may be triggered by a stressful event like illness or surgery. And that's the clinical onset. The pump problems are probably pre-existing, and it's just that there's something that that happens that suddenly causes things to deteriorate. Once the heart muscle weakness begins, it can decline fairly rapidly over a period of several months, and it doesn't always respond to our usual toolbox of medications. We have our usual heart failure treatment, and in other forms of heart failure, we manage it and the heart can get better. But my experience and what other clinicians have seen with this is that sometimes the heart function is almost inexorable progression despite our best efforts to try to stem the tide. And the symptoms can be subtle. And in some patients, they have a lot of gastrointestinal distress, which is actually a subtle sign of cardiac dysfunction. And it can present with intermittent nausea, some diarrhea that continues and keeps coming back. And that can indicate that the heart is not sending enough blood flow to the gut, or that the pressure in the veins in the gut is elevated because the heart is failing. And so that if you're starting to see new GI symptoms, make sure you go back for an updated cardiac evaluation ASAP, because that can be an unrecognized sign of heart problems. And then swelling of the ankles is often seen in the later stages when the heart muscle is not effectively producing good contractions. And that's because the pressure builds up and the fluid doesn't get circulated well. And we diagnose pump problems with imaging tests, with echocardiography, which is ultrasound of the heart, or cardiac MRI. And just to show you what those look like, most of you have been familiar with the echocardiogram, which is basically the provider will place a wand over the chest with a little slimy jelly and take some images, and it looks something like this is what the images that we see. And you can see those nice 4 chambers of the heart, and you can see how well it's beating, and you can look at the valve function. So this is a nice, easy, non-invasive bedside test, and we do this quite frequently in our office. And then cardiac MRI is a more extensive test. The child will lay on a table and slide into this giant tube, which then uses a big magnet to help image the inside of the heart. And this, although it is non-invasive, it's a lengthy test, and it can be, we usually put an IV in place to give a special contrast material. So this is a little bit harder for the kids to endure, because it can take up to an hour or 2 of lying flat, and that can be a challenge for some children. And these are the images that we see with MRI. And again, this is kind of an upside down view, but you see the 4 chambers nicely. It tells us both how well the heart contracts, similar to the echo, but this also gives us lovely characterization of the muscle tissue and shows us when the muscle is being replaced by scar tissue, which can give us a sense for progression of disease before clinical symptoms arise. So then addressing how do we identify electrical problems. As I mentioned, these premature beats can begin in the first decade of life, and they become more frequent and more sustained as you become a teenager. And atrial fibrillation, if you're in it for a sustained period of time, it can increase the risk of clot formation within the heart, which can lead to stroke. So this is a really important thing to be proactive in identifying. And heart block, which is those slower rhythms, can progress gradually, causing the heart rate to slow down, and it's typically occurring a little bit later in the course. And these are the various tests that we use. The electrocardiogram, which you're all familiar with, I think, is where you put some stickers on the chest and it leads to the computer, and we get a printout of the rhythm, but we're only measuring it for 10 seconds at a time. So it's easy to miss things that are intermittent. So for that, we use something called a Holter monitor. And the classic Holter monitor is done for 24 hours, but now we can do extended monitoring for 48 or hours, or even up to 2 weeks at a time. And the classic Holter monitor looks something like this, where you put a bunch of stickers on the chest attached to wires, and it's attached to a little box that, in this case, the child has it in their pocket. But the newer Holter monitors are much more easy to use. They're little patches that you can see stick onto the chest here and here, and they can be left on for 2 weeks at a time. And the new ones are waterproof. This little guy's taking his bath, so that's very nice. And that gives us a much better, more sensitive way to pick up intermittent irregular rhythms. And then the implantable loop recorder is basically a continuous Holter monitor that is put underneath the skin and is left in place for years at a time. And it allows the advantage of continuous monitoring all the time, every day. And it transmits the data wirelessly from a monitor is placed in the child's bedroom typically, and it will communicate with the device and upload all the data, and then it can send it to the physician, who can then review it. And typically the battery will last about 3 years. And once the battery is gone, you can take the device out and put a new one in. And this is what it looks like. It's a small little, almost like a memory stick that you would put in a computer. And it goes here in the front of the chest, under the skin. It's implanted just underneath the skin. And it's done with a very minor surgical procedure where the surgeon will just sort of pinch up the skin, create a tiny little nick in the skin. And then there's just like a little plunger device. They slide it in and insert the device, and then put a little stitch in there and close it up. So it requires very brief period of anesthesia. And then once it's in place, this is the device that you leave in the child's bedroom, which then communicates. Usually it's programmed maybe at 2 a.m. every day. It will scan the room, and if the device is located within a 20-foot radius, it will upload all the data and send it on to the company, which then produces a report. If your child happens to be sleeping over at grandma's house and you don't have the device with you, that's fine too, because then the next time it is within range and it picks up the data, it will download everything since the last time it downloaded. So you're not going to miss anything. And it's a very handy way to continuously identify problems. So that's how we diagnose the issues. Then the question is, how do you treat heart problems? And the first thing I wanted to put in a plug for optimizing pulmonary care, because a sleep apnea or hypoventilation really have a negative impact on heart function. And so that is first and foremost, to make sure that the pulmonary and sleep issues are addressed. And then medication can help. And typically we use medications to improve pump function when we start to see that deteriorate. But as I mentioned, sometimes the heart function can deteriorate despite our best efforts with medication. And then we also will use medications to help control the rhythm. If it's too fast, we have meds that can slow it down. And then if a patient's in persistent atrial fibrillation, we often recommend anticoagulation to prevent those clots and the stroke risk. And then this is the important piece, is the implantable cardioverter defibrillator, which is recommended for what we call primary prevention. In other words, we want to put these in before a dangerous rhythm occurs. We don't want to be reactive and wait until we start seeing bad rhythm problems on the monitoring, because then it may be a little bit too late. I mean, we really want to be prevent issues from occurring. So the big question is, at what age do you put these in? It's not easy. And you would say, well, why don't you just put it in as soon as you diagnose the problem? But these devices are challenging in small bodies, and they have complications. And so we're trying to weigh the risk and the benefit. And what an ICD looks like, it's basically an electrical device that gets planted, again, under the skin in a little pocket in the upper chest. And then it's attached to these wires which go through the vein into the heart. And there's typically one wire that goes to the upper chamber and another wire that goes to the lower chamber. This is called transvenous placement. And in a small child, this is really problematic because the wires can actually obstruct the vein, which is no good. And as the child grows, there's this will pull out because this doesn't allow room for growth. So an alternative, if you need to do this at an earlier age, I just wanted to show, this is what it looks like after implantation. This, of course, is an elderly gentleman, but the devices are big and bulky and go under the skin. And so if your child is very skinny and doesn't have a lot of subcutaneous fat layer and doesn't have a good muscle layer, they do stick out. They're not painful. Once the incision is healed, usually they don't bother the children, but they are certainly big. And so for tiny bodies, that can be really a challenge. So an alternative is something called a subcutaneous ICD placement, which we're starting to use in younger children. And this is where the box gets placed outside the rib cage, under the skin still, but it's placed over here. And the lead, instead of going through the veins, the lead goes under the skin into the front of the chest, and it can still provide monitoring and the ability to provide an electrical shock if needed. And that's basically what a cardioverter defibrillator is it will monitor the rhythm. When it detects that the rhythm becomes unstable and is going into a cardiac arrest situation, it will deliver a huge electrical jolt to the heart to basically restart the heart in a normal coordinated fashion. It's basically the same thing as you'll see on television in the emergency room situation where they place the paddles on the chest and give a big jolt and the body jumps off the table and it restarts the heart. This is the same type of idea, but it's done from the inside out. So it is life-saving when it works. It can also be fraught with difficulty because there are such things as inappropriate shocks where the device thinks it's recognizing an abnormal rhythm and delivers a shock inappropriately when there really isn't an abnormal rhythm. And that can happen sometimes from noise, or if the lead gets fractured, or if there's interference from something. So we certainly don't want to put these in unnecessarily. They can get infected, they can erode through the skin, and they require maintenance. The battery needs to be replaced periodically, which requires additional surgery to explant the unit and put a new one in. And it also requires regular trips back to the cardiologist for testing. So that involves more doctor visits. So in general, we would love to be able to wait until kids are at least close to their sort of preteen size before we implant these things. So somewhere in the 9 to 12 age range is sort of the minimum that we would be able to typically put one of the transvenous pacemakers. But if we're detecting dangerous rhythms earlier on, we could consider more of a subcutaneous type device, which is a much newer technology. So that all has to be done thoughtfully and in consultation with your local cardiologist. But I would recommend, many cardiologists will wait until they start seeing evidence of ventricular arrhythmia on the Holter monitor or on the Link monitor before they consider recommending one of these devices. And I would argue, knowing what we know about the risk of sudden death in LMNA patients in particular, I would argue for putting these in before you start seeing a ventricular problem. Put them in early to prevent a sudden death from occurring. All right, I think that's the end of my slides. I hope that was.
Do you think there will be data coming out of more use of the loop recorders, the continuous loop recorders, to be able to predict this potentially fatal arrhythmia situation earlier, that will then help you to pull the trigger on the ICD at the appropriate time? My hope for the Link devices really is that there will be accumulative data that kind of starts raising a red flag before it actually happens. So like an accumulation of certain abnormal rhythms that do not rise to clinical significance, but are recognizable in the Link device. And when they occur with a certain frequency, unfortunately often at night, of course, that one then can trigger the ICD device before a near miss actually happens.
Yes, absolutely. And I'm hopeful. There's this ongoing trial in Spain using the Link device, and I don't know what the current status of that is or how much patient data they currently have, but it's unclear to me if seeing progressive rhythm problems on the link monitor, how well that predicts those who are going to have a sudden cardiac arrest. I think the cardiac arrest issue can happen even in patients who don't have known underlying pre-existing rhythm dysfunction, so that until we analyze the link data, we won't really know how predictive it is. I'm hoping that it is predictive.
Yeah, that's why I felt this was a high priority research item on our agenda.
I'm looking in the chat question. Someone asked, would we recommend doing a link monitor, and if so, at what age? And I do. I think that the link monitor is extremely effective from the clinical standpoint. As the cardiologist, it gives me a good handle on what's going on, and those can be placed even in younger children as early as age 5. I think that's a reasonable thing to do. Even I would start doing those Holter monitors right from the time of diagnosis, a minimum of once a year, if not, more often if you're starting to see problems. And then the link monitor, once you put the link monitor in, that takes away the need for doing the external Holter monitors. And I would do them even in young preschool and school age children if you're starting to see problems on the Holter monitor, for sure.
If a link device is not available because of local circumstances and so on, what is the minimum length of a Holter monitor recording that you would recommend?
Oh, that's a great question. If you have the availability of those patches, those can stay on for 14 days at a time, and that gives you a really good sense of what's happening without symptoms, so I would do those.
Dr. Beth McNally was just putting that in the chat, exactly that. And Beth, you can unmute yourself and talk to that patch monitor, the role of patch monitors that you also just mentioned.
Yeah.
She and I would also unmute.
I would also argue that if your local cardiologist is not so familiar with LMNA risk factors, and they're reluctant to be aggressive, and they're reluctant to put the defibrillators in because they're basing it on standard ICD inclusion criteria, I would encourage them to contact Cure CMD or contact me. I'm happy to chat with anybody and just sort of encourage them to be more proactive and not use the normal way we do this is reactive. We wait until a problem occurs and then we place the device because we don't want to put the device in unnecessarily, obviously. But in this case, I think we need to be a little bit more aggressive.
Dr. McNally can unmute now.
Beth, do you want to talk?
Oh, I have to unmute her again. There it is.
Sorry about that. Can you hear me now?
Yes.
All right. Sorry, I kept getting unmuted again because I switched devices. That was a wonderful overview, Dr. Heller. Thank you so much. I have to say, I'm a huge fan of the patch monitors. It's so much easier to be able to do these right now than the old-fashioned Holter monitors. And so I always try to get 14 days whenever I can. There's, it works great. You can take a shower and bathe and do all those things that we talked about that we couldn't do before. So, a negative 14-day monitor, I actually think has a lot of value to it. And the loop recorders are again, a huge advance in being able to have that available. Some of the limitations we encounter is that insurance doesn't always cover it. And that's probably some of the battle that we do have to face with that, is that you do need a approval for insertion as well as approval for the monthly cost of monitoring, and that's where we sometimes bump into it. And that's in part because it is a newer technology, and so sometimes insurance is less familiar with it. For any clinicians who are listening, or even the patients and families, I often find if you just write the genotype in the indication, that often goes a long way towards getting an approval for something. So that can sometimes save a phone call for approval. But yeah, the loop recorders are great. I think the future is really correlating what we see on our imaging with what we get on our monitoring and developing what we call a risk score based on that, and then being able to use that information going forward in deciding who benefits most from device.
Yeah, that's really helpful. Exactly, that should be priority number one here.
Well, I would love to continue this conversation, but we are unfortunately out of time today. I'm sorry to our audience members who have asked us questions that we couldn't get to. We'll try to get to you as soon as possible within the next couple of weeks on those questions. But in the meantime, thank you to our panelists so much. This was very insightful. And thank you to our audience members for joining us. We hope you enjoy the rest of your SciFam experience.
Bye.
Thank you, everyone. Bye.